Alright guys, welcome to today's video, and really sorry about not posting for a few days. I was just preparing a few chapters myself for the upcoming videos, and in these chapters I've taken the notes from a lot of the online courses that I myself or a few of my friends had purchased. I've taken it from the past 2 months, the most recent ones, the recalls from the last 2 months, which was March and February 2026, and then from John, the text in it is from John Murtagh, and also the recent guidelines. And as you can see, the date on the top left side of this guide, this first chapter, which is the March of 2026 right now. Today is the 23rd of March, and I'm saying this date because later on maybe a few of the guidelines may change, maybe a few more recalls will come, and then we can add more information to this. Now, the aim of this chapter is to make it sort of a revision chapter. So if you are starting your journey right now, this would be a good chapter to get a guidance of what is important to study, how the AMC is going to ask the questions, what are the important points or topics you should focus on, and some that you should not focus on or waste your time on. And then I've also added the ECGs that are related to ischemic heart disease. As you can see, this is the first chapter for us. And other than that, I've added a few trial questions. I've added the guidelines right now through the RECGP Red Book, and and the different values that you should memorize, or the different mnemonics that would help you answer the questions. And over here I also have my topics that I prepared, that I've compiled for every single system, and under every single system there is a subtopic. The subtopic is related to the system, obviously, and all of these are system wise. So all of these are topics that are either mentioned in courses online, paid courses online. They came in the last March and February's recalls, and they had a lot of questions from it. Now I have divided these into different chapters. So today we'll be focusing on ischemic heart disease, which is the first chapter that we'll be working on. Then this is what the video is going to be on about, and I'll try to keep it short so that this could be a short video for you. You can just come back and review, and maybe try to keep it under 15 minutes so that in an hour you could go through 4 or 5 chapters at the same time, even more if you put it on 2 times the speed. Now if you want to go through these topics, these important topics, the chapters under each subspecialty, I've shared this exact document in the WhatsApp group. And to join the WhatsApp group, there's a link given in the description. You can just click join the channel, and then you can access these documents. Right, now let's begin with our chapter today. Now in the cardiology section, it was really important because in the last recall they had approximately, you can see, 14 questions that were just from the cardiology section, and right now we're just doing one chapter from the cardiology section. So you should keep in mind that there's a lot to cover, and if you're on time crunch, then try to just focus on the important points that have a lot of questions coming from them. Those could be ECGs or the different diagnostic criteria, the algorithms to diagnose. All right, and before we start studying, I also want you to always keep this one point in mind. When you're going to study right now, don't take it as something that's stressful or something that you need to complete or something that you're doing for the exam, because that used to work when you're in university. But right now, every time you study, keep in mind that maybe whatever you're studying right now, maybe 1 point, 2 points, whatever chapter you're studying right now could help a patient in the future, could make somebody's life better, could save a patient's life. So if you have that mindset, then you'll realize what's at stake, not just your exam but somebody else's life, and that way you'll pay more attention to it, you'll understand it more, and mentally you will be prepared. If there's, let's say, a person has a side effect because of a treatment, you will know, okay, this could be a side effect, how do I treat that in a real patient? And because of that thinking, when you go and sit AMC, and AMC does ask those questions, because I said in the last video, if you haven't watched it, go have a watch, that they ask you questions that an intern in Australia should know. So that's basically you preparing yourself to be an intern in Australia with that mindset and with those questions in mind. All right, and then today's learning objective, you can read this in your spare time. We'll just start with it. And high yield topics. The first one, troponin interpretation, it's very, very high yield. I've seen multiple questions from it, especially the troponin measure being normal in the first few minutes, but then later on deteriorates or increases, and you need to know that time period. We'll be covering that as well. Then ECG territory localization, if it's anterior, lateral, inferior, or lateral only, and we'll be going over those as well. I have a few ECGs over here that go over all of these different sections, and we'll be going over those as well. Now, then we have also PCI and thrombolysis, very important topic, right ventricular infarction and its management, because the management for right ventricular infarction is completely different than for the other infarctions. Then post-MI complication timelines. This is very important because every single every single hour, day, month, or week has a different complication related to in post-MIs, and AMC likes to question about it a lot. And then secondary prevention drugs. Now, along with secondary prevention drugs, there also will be lifestyle changes, and AMC is known to question that. Or let's just jump into it. So we'll be these are all the contents for the chapter. All right, and yeah, let's start. And towards the end of the chapter, if you want to just revise, so these two last two sub chapters or subtopics are just enough, because they'll include all of the mnemonics, all of the different values, and all of the references to the drugs, to the time period, and to the readings of ECGs. All right, so that's just enough for you to revise as well. All right, now let's start. So pathophysiology isn't a question that comes a lot. They won't ask you for it, but if you know it, it's very good for you, because it will be easier for you to understand the pharmacological treatments, the algorithms. All right, so I've taken this from John Murtagh, because the number ACS and congestive coronary heart disease is the most fatal cause, and you have to suspect that in any patient that comes with angina or chest pain. All right, so IHD remains the leading cause of, we'll start from here, it's the leading cause of death in Australia and worldwide, and it's going to directly translate into exam weightage, because if it's the most leading cause, you'll have a lot of questions about it. All right, so in Australia, it accounts for 18% of all deaths. Now, this is from 2017, because this is the data I could find. And the rates have fallen tenfold since 1968 due to smoking cessation campaigns, statin therapy, and emergency revascularization. And then ATSI population, it specifically flags that CVD risk assessment should begin at age of 35. In all ATSI or Aboriginal Torres Strait Islanders, it's always important that we start all the screenings earlier. We always consider the highest risk factor, and ATSI group unfortunately comes under the high risk group for a lot of the diseases, including obesity, diabetes, then CVD, and a lot of other pathologies that we'll be talking about as well. All right, so moving on, we move on to the definitions of it. What is IHD? So ischemic heart disease, it's a broad term or an umbrella term that is used to describe any condition in which the myocardium receives insufficient blood supply, and this could be due to atherosclerotic narrowing or occlusion of one or more coronary arteries. And this is also important to know what is the difference between an embolism and a thrombus. An embolism is a thrombus that formed but then got dislodged and then got itself stuck in a narrower artery or a vessel down the line. However, a thrombus is just attached to it. An embolism would be a thrombus that got detached and it moved. All right, so thrombus for this, embolus for this. All right, now coronary artery disease, it's a synonym for IHD in most clinical contexts. All right, and encompasses the full spectrum from asymptomatic atherosclerosis to stable angina, ACS, and sudden cardiac death. ACS is acute coronary syndrome. All right, and we'll be looking at it later on as well. Yeah, I have it right here, acute coronary syndrome. So stable angina, it is reproducible chest discomfort that is precipitated by exertion or emotional stress and relieved by rest or nitrates within 10 minutes. All right, and it's caused by fixed coronary stenosis producing supply-demand mismatch, and it is not a part of the ACS. And we need to know that what is reproducible and what is non-reproducible. So stable angina versus unstable angina. All right, ACS, it's again an umbrella term for acute life-threatening presentation of CAD. So CAD, if it's life-threatening, it converts into an ACS, and it is caused by abrupt, so sudden reduction or complete cessation of coronary blood flow, and is usually due to plaque rupture or thrombus formation. All right, and encompasses STEMI, NSTEMI, and unstable angina. Just keep in mind it's unstable angina, not stable angina. All right. Now the 3 ACS presentation is the SNU classification. All right, stable angina, NSTEMI, and then unstable angina. All right, so stable, STEMI, NSTEMI, and unstable angina. Sorry for that. So S is for STEMI, N is for NSTEMI, and U is for unstable angina. And it's going to rest on 2 findings. So we understand this way. So SN and NU. So SN would be ECG specific, where SNU would be troponin specific. All right, you'll understand this later on. So stable angina, normal at rest, ST depression on exercise and stress levels. Alright, so reproducible. You are going to see this depression with exercise. Troponin, normal. Alright. Underlying mechanism is fixed partial stenosis, supply-demand mismatch on exertion only. And pain duration is less than 10 minutes, and if you give a GTN, it's relieved. Critical teaching point would be it's not a part of ACS, and reproducible and predictable. Now moving on to unstable angina, there's ST depression, T-wave inversion, or there's a normal ECG. All right, whereas we had in stable angina, we had an abnormal ST depression while they were exercising or there was a stress. And troponin is normal. All right, now this is an important point, because when we go to differentiate between the SNU classification, we can differentiate using the troponin as well. And it has normal troponin level. This is most tested AMC distinction, and usually pain is more than 20 minutes and may occur at rest or without with a minimal exertion. All right, that was unstable angina. Then we have NSTEMI. NSTEMI means non-ST elevated MI. So ST won't be elevated in this. So there's ST depression, T-wave inversion, or normal ECG again. And this, however, the troponin is elevated. All right, and elevated troponin plus no ST elevation is equals to NSTEMI, and we do not give thrombolytics. All right, in STEMI, the name suggests STEMI, so ST elevation more than or equal to two contiguous leads. All right, contiguous leads basically means that the leads that are showing you the results of just one side or one continuous side. So we'll just quickly come to this ECG here. So contiguous leads for this would be the inferior ones, the lateral ones, or the interior. So it has to be just from one group itself. It can't be one lead from inferior, one from lateral, one from interior. That doesn't work. That's not contiguous. All right. And AMC, now this is the text in red is always going to be AMC traps or important points that AMC is known to test about. All right, so the most important distinction that you are going to be tested is NSTEMI versus unstable angina, because both can have identical ECG changes and identical symptoms, and the only differentiator is the troponin. So remember over here I said that NU and SN. So NU is troponin, whereas SN is going to be ECG changes. All right. All right, so the again, this is a short form. At the end of the chapter, you can revise this once, the important table of it. All right. Pathophysiology, so there are 4 steps to it. We call that in cascade. However, it's not very important for the AMC because I've not yet seen any questions about it. However, if you want, you can give this a read. All right. And why does this matter for the AMC? As I said, that STEMI is complete occlusion. That means transmural. Transmural means the full thickness infarction, and there's going to be an ST elevation on the ECG. Whereas NSTEMI is the partial occlusion. It's not transmural, and there's going to be ST depression on the ECG. All right, and UA, which is unstable angina, is going to be partial occlusion, and there's going to be ischemia only, but no necrosis. And troponin is going to be normal. Why is troponin normal? Because there is no necrosis. Troponin relates to muscle injury, cardiac muscle injury that releases troponin cells, and we get those readings. If there is no necrosis, then the troponin is going to be normal. However, unstable angina can get further complicated. We could have troponin later on, but that's a different story. Right now we're just focusing on the immediate points. All right, so the mechanism only explains why the treatment differs. As I said earlier, if you know the pathophysiology, you will understand why the treatment is going to differ. All right. Yeah, so we come to the risk factors. Now, what AMC loves to test about is modifiable and non-modifiable risk factors. And it's really straightforward, because modifiable would be the risk factors that the patient has a control over, whereas non-modifiable are those risk factors that the patient has no control over. So age, gender, family history, premature menopause. So premature menopause, it's a weird risk factor, because sometimes due to certain controllable or modifiable risk factor, the patient does happen to have premature menopause, and that could lead to non-modifiable risk factor, which is premature menopause, and that could include obesity, drug usage, alcohol usage, a lot of stress, bulimia nervosa, anorexia nervosa, BMI that is too high, BMI or that is too low, and then obviously ethnicity, that is different groups have different susceptibility to different diseases. So higher rate in South Asians population, and as I said, ATS high. All right. All right, there we go. So AMC is going to construct scenarios. So they will give you maybe the ethnicity, the family history, the age, or the gender, and then give you those diseases. And this is not just for cardiac; it's for every single pathology that will test you about. And you'll have to keep a patient profile in mind, that certain patients are going to be more susceptible to certain diseases. All right. Now moving on to the cardiovascular risk assessment in Australia. All right. So we have calculators for it. We have different. I'll be going over the different tables that we have. We'll be going over different classifications, Gillick scores, different calculators. But you can use. That's not a question that's going to come in the exam. They won't give you that you need to calculate it, but they'll give you every single detail about it, and the end calculation, and ask you, what does this mean. All right. So Australia in absolute cardiovascular risk calculator, so auscvdrisk.com, AU estimates 5-year or 10-year risk of cardiovascular event. And they expect us to know that all adults more than or equal to 45-year-olds, indigenous are ATSI, so 35-year-old without known CVD should have absolute CVD risk assessed every 2 years. All right, so 2 years for them. All right. Patients with established CVD, diabetes, or aged more than 60 or hypertension are automatically high risk, so no formal calculation is needed. And high absolute risk would be more than 15% over 5 years, so commence preventive pharmacotherapy for them. All right. Now clinical presentation. All right. So we have Socrates. Socrates is the mnemonic we use for describing pain, and then we have the PQRST analysis. So first we'll be going over PQRST. So P is provocation, Q quality, R radiation, S would be severity, T would be timing. All right. So P provocation or palliation. What is going to increase it, or palliation is what is going to decrease the pain. So if it's sudden onset or at rest, so if it's at rest, then it's going to be unstable angina, because stable angina is the one that is going to be produced by stress or activity. Or it is consistently reproducible on exertion, not relieved by posture, food, or antacids, because posture would be pericarditis or just fluid buildup around the heart. Food could be, or antacids could be GERD, or excessive acid production, or pyloric stenosis that could cause the acid to build up in the stomach as well. But there are a lot of differentials. So if pain is relieved by antacids, consider GERD or esophageal spasms. If pain is positional, then think pericarditis. If reproducible with just chest wall palpation, so if you're squeezing the chest muscles and there's a reproduction of this pain, then it's going to be musculoskeletal but not cardiac. And this is a very interesting one, because we had a patient come in. They had pain over the left chest. We did all tests. Everything was normal. Turns out he held the camera for too long and his muscle got sprained. So that was it. So there was no need for doing all those tests. Anyway, so quality of the pain is crushing, squeezing, pressure, tightness, heaviness, or so this has come in the exam, like an elephant sitting on my chest. All right. This I've seen this in the recalls, that they give this sentence as what the patient is feeling like. All right. And clenched fist. So this is the Levine sign. All right. They will tell you maybe that the person has a clenched fist sign, or they will tell you that he has a Levine sign. All right. And they expect you to know this. They could just write Levine sign, and they expect you to know what it means. All right. So just keep this in mind. Then sharp or stabbing pain is unusual for ACS. All right. Sharp or stabbing pain. So where do you see sharp or stabbing pain? It could be pleuritis, pericarditis, pneumothorax, or musculoskeletal, and also of aortic dissection if the stabbing pain is going through the chest. And now stabbing pain towards the back is also seen in the abdomen for pancreatitis. So keep that also in your differentials in the lower side, but it is also seen in pancreatitis. And again, how do you differentiate? You read the history and everything. All right. Now radiation left arm, which is the most common. All right. Tip of the shoulder, that's also common, but you have to also differentiate, because sometimes the tip of the shoulder pain is due to pancreatitis as well. All right. So radiation to the back, especially tearing, it's going to be aortic dissection. All right. Never give thrombolytics in this scenario. All right. Now severity. usually severe, so 7 to 10 out of 10. However, severity does not reliably predict ACS, because sometimes the patient is on painkillers already, they've been taking ibuprofen, they've been taking let's say they have other pathologies for which they've been taking drugs, or they have diabetes. So diabetes so you know that in diabetic patients that the pain reception is not as sharp as it would be in in person who is a non-diabetic. All right. So AMC traps, again, diabetics and elderly patients, a woman who has mild atypical or absent pain. Women usually tend to have milder pains, especially for chest, as compared to men. So unrecognized, this was from John Murtagh. More common in diabetes, hypertension, elderly, and females. So chest pain, as we said in the beginning, we never dismiss after we, if we suspect it, because it's life-threatening. All right. So timing would be more than 20 minutes. Suggest infarction. All right. Stable angina resolves within 10 minutes or with rest or GTN. STEMI pain is usually continuous and is not relieved by GTN. All right. If pain lasts only seconds, it's not ischemia. If pain resolves then recurs, then it's dynamic ischemia. High risk and STEMI, unstable angina scenario. All right. So Murtagh says if angina like pain lasts longer than 15 minutes, then MI must be excluded. All right. So this is the time frame. Longer than 15 minutes. They could give you this in the exam as well. 15 minutes. So keep that in mind. Associated symptoms. They will give you these presentations in the beginning of the question, that beginning of the stem of the question, that the patient has diaphoresis. That means there is sympathetic nervous system activation, and it is one of the most specific symptoms for serious cardiac or hemodynamic compromise. Then nausea, vomiting, particularly common in inferior MI due to vagal activation from the RCA distribution, which includes the SA and AV nodes. Dyspnea, it may indicate left ventricular dysfunction, pulmonary edema, or reduced cardiac output, because if there is reduced cardiac output, the brain is going to receive less blood, which means less oxygen, leading to dyspnea. Leading to syncope. And dyspnea is more, right-sided. But again, dyspnea, which is shortness of breath, could show left ventricular dysfunction, pulmonary edema. So left ventricle is not able to pump out the blood as fast as it should. There's blood buildup on the right side. Before the right side, there's the lung. So there's going to be shortness of breath because the lung is going to start filling with fluid. All right. So pulmonary edema, we get that, or reduced cardiac output. Dyspnea alone without chest pain may be the presentation of ACS in some patients. All right. Syncope or pre-syncope suggest hemodynamic compromise, complete heart block, or ventricular arrhythmia complicating ACS. Pallor, sympathetic vasoconstriction, reduced cardiac output, and it is explicitly as an ACS red flag pointer. All right. Palpitation, so arrhythmia, ventricular ectropic. So you can just think about it that if the muscle of the heart is not receiving the blood properly, then there are going to be arrhythmia. So SAAV nodes, the fibers are not going to receive enough electrolytes, enough blood. So there's going to be arrhythmias. All right. And they're common in the peri-infarct period. All right. Now silent MI is a critical AMC teaching point. All right. So unrecognized MI is roughly equally divided into atypical or silent, and more common in diabetes, hypertension, elderly, and female. All right. Important. In this group, ACS may present as fatigue or generalized weakness alone, nausea, vomiting, or ingestion without chest pain, because these groups, so hypertension, diabetes, and elderly, are already taking other medications. So for them, pain could not just be the presenting factor. It could be a lot of these other factors. All right. So fatigue, generalized weakness alone, nausea, vomiting, dyspnea, epigastric pain, collapse, or syncope. That's why I went over this whole list, because it could be that the patient does not present with pain. However, they still have an MI, which is a silent MI or unrecognized MI, and they still present with all of these symptoms. All right. Good. So physical examination findings, we'll have the same ones: diaphoresis, hypotension with so SBP is going to be less than 90, and tachycardia with raised JVP, clear lung fields, and bradycardia. So it shows that what's the significance, which side is getting more affected because of these symptoms. All right. So right ventricular infarction could mean hypotension and raised JVT. Then we have so actions required. We'll come to those in more in detail later in the chapter. All right. But give this a read as well, because it's very important for you to understand what type of heart failure it is, or MI it is, and if you know what type of an MI it is, you would know what type of drugs to give, because in right ventricular we don't ever give nitrates, because right ventricular heart failure, right ventricular MI is always going to be dependent on preload. So if you give them nitrates, that's going to decrease the preload even more, and this is going to worsen the patient's condition, and could mean that the patient is going to die, or it's going to require longer hospital stay, more bigger bill, a lot of other complications can occur. So just keep that in mind, it's very important. So pulmonary crackles, S3 gallop, left ventricular failure, new pansystolic murmur, left sternal border pansystolic murmur. So if it's pansystolic, there's something wrong with the septors, okay, right? So it could be ASD, VSD. So left pansystolic murmur with left sternal border is going to be VSD. New pansystolic murmur, which is going to be at the apex, radiating to the axilla. So there's going to be acute mitral regurgitation from papillary muscle rupture. Now this is important because papillary muscle rupture complete tear, it's very rare, but it does happen, especially in patients of MI. All right, it could not be the first presentation that the patient has of having acute mitral regurgitation because of the papillary muscle rupture, because you could know that that we have a lot of papillary muscle that are attached to one leaflet, so all of them being ruptured or torn could mean there's a serious complication, serious pathology going on with this patient. Pericardial infection or pericarditis. All right, and we need to differentiate between pericarditis or Dressler syndrome, because these are important points that AMC will test you upon. All right, unequal BP in both arms. I've seen a lot of questions for these. All right, aortic dissection, not ACS. All right, never give thrombolytics for them. Urgent CT arteriogram, but before we do CT arteriogram, we have to give them, we have to see if the patient is hemodynamically stable. So if their blood pressure is very, very high, we have to give them IV labetalol or IV beta blockers to lower that blood pressure, and then we can send them off. All right. I've seen, I think, 3 questions for just this, giving IV labetalol or IV beta blockers to the patient with aortic dissection. All right. Now moving on to the ECG interpretations and territory localization. At this point, if you've watched this video continuously, at this point it's a good point to take a break, because from this point onwards we'll be going over the more complicated parts of this chapter. So it's better to just take a 2-minute, 3-minute break, come back to this video, and then resume from here. All right, so ECG interpretation and territory localization. A lot of the questions will come on this as well. They could give you an ECG or ask you, they could give you an ECG and ask you what do you think it is, which part or which vessel is going to be the affected vessel, because first they used to ask which part of the heart, is it anterior, lateral, inferior, or just lateral is affected, or posterior. But right now they've also started asking about the different vessels that are going to be affected. All right, so there's a 5-step approach to it. However, I will not be going over the different vessels that are affected. We'll be going over the different vessels in the next chapter, because it's more related to that chapter. However, we'll still be going over the basics of reading ECG. I'll not be teaching every single thing that what is PQRST, how do you measure it, 25, if it's a 10-second step, all of the different leads. But I'll be going over whatever is relevant to this topic. So there's a 5-step approach. So rate, rhythm, axis. This is what we learned in university. Then we start measuring the intervals: PR interval, QR interval, and QTC. You need to remember these values, because these values you're not going to get an exam. All right, they'll maybe give you a value for it. They maybe give you just the ECG. They'll maybe give you an ECG and ask you that you count them and tell them what's wrong with this. And then STT changes and Q wave. So identify any ST elevations, ST depressions, T wave inversions, hyperacute T waves, or pathological Q waves. All right, so another MI that has started coming more into the exam is the posterior MI. Now, just remember, just keep this as a tip in your mind, that if you see any disease that's getting more famous in the community, such as this posterior MI, it is likely that you will get a question about this in the exam. And this is just something extra that you could do. You could look up the researches that are recently being published about pathologies and see if there is any that you don't know. So posterior MI was technically a rare one for me. It was a newer pathology for me, because we didn't study about that in the university. We just knew about anterior, inferior, and lateral. They told us about that posterior is possible, but they didn't teach us they didn't teach us the scenarios, they didn't teach us about the patients. However, posterior, well, keep this rule in mind, that whatever MI you see, you're going to see ST elevation and then the reciprocal of it in the opposite leads. So if there's ST elevation in the anterior leads, you'll see depression in the if there's in the posterior leads. So there's no posterior leads, but if it's on the let's say I'll show you some examples so that you can drive this point home. But you will see a reciprocity of it in the other leads. All right, so STEMI diagnosis, so 1, 2, 3 AVL, AVR, and AVF, ST elevation more than 1 mm in more than 2 anatomically contiguous leads. Pericardial leads are V1 to V6. Left bundle branch block would be there's going to be other ECG findings. However, there is a way of looking at it through the axis deviation. All right, then posterior MI there, so this is an important one. Posterior MI, so ST depression in V1 to V3 with tall R waves, mirror image, so perform posterior lead. So we need to, so as you know that it's V1 to V6 that we have, but you need to do 7, 8, 9 to confirm this ST elevation. All right, good. So now we'll be going over all of this, just go over this table. This is very important because if you can learn this, and I'll show you a way of learning them easier, in an easy way. So if you can learn this, then you'll be able to solve any single ECG that they send your way. As I was saying, they could give you an ECG and ask you for the pathophysiology, or what they could do is they can give you the whole stem and then give you 3 or 4 or 5 ECGs and tell you to pick one that could be this person's ECG. All right, so anterior is V1, 2, 3, 4. Anterior lateral is, so it's anterior plus lateral. All right, so V1 to V6, the first lead and the AVL. Then high lateral is 1 and AVL. Just lateral is 1 AVL, V5 and V6. Inferior is 2, 3 AVF. Posterior is 7, 8, 9, and we need to get the posterior leads. And ST depression in V1 to V3 plus tall R waves. So which is V1 to V3? So V1 to V3 was the anterior leads, right? So V1 to V3 was the anterior leads. So we're going to see a reciprocal of it in the anterior leads for a posterior STEMI. All right, I mean it's written here as well. All right, so right ventricular is V4R, right-sided ECG. All right. Now, in the beginning when I was studying, this was difficult for me to remember. However, I came across this hack and this tip, and I think you guys should also have it because it made understanding ECGs and seeing where to see it very easy for me. All right. So now, how do you remember which is inferior, anterior, or lateral? So for inferior, you draw an I from 2, 3, and AVF. That's an I. All right, so inferior. Now for anterior, you draw an A starting from V3 and you draw it onto a V4. So that's our anterior leads. Now whatever is left, so we don't consider AVR for now. All right, we draw an L like this. So now we have our lateral leads, we have our anterior leads, and we have our inferior leads. You see, now for none of the leads, they are going to counteract with each other. For example, let's say if anterior septal is V2, that we have for lateral, so we have to see V2. That is not true. However, if you want to see anterior lateral, then yeah, you'll have to see them as well. So first you see the anterior leads, then you look for the lateral leads. And you can also check the other leads. So the way is that the way I use, I first draw the inferior lead line, then the anterior, and whatever is left is going to be the lateral lead. All right, we don't consider AVR while we're drawing them. All right, AVR is also very important, but we don't consider it while we're drawing this. All right. All right, so now moving to our so important points is that RV infarction. Again, this is a trap. All right, because the pharmacological treatment for right ventricular is completely different from the pharmacological treatment for the other MIs. All right, and in this combination, right ventricular infarction, we are going to have inferior STEMI, hypotension, raised GVP. So raised GVP is completely clearly right-sided, and then clear lung fields with bradycardia. Now, why do we have bradycardia? Because the nodes are not getting activated, and then we don't have contractions. Now, as I said earlier, that right ventricular is preload dependent. That means, so if you don't know what is preload, think of the heart as a balloon, which it is. So preload is the amount of air that is pushing against the wall of the balloon, and in this example, so we'll have the amount of blood that's pushing against the walls of the heart. All right, and afterload is the resistance it feels from the blood already in the circulation. And in this, it is completely contraindicated to give nitrites because it could reduce preload, BP crash. All right, patient could die. Diuretics, because again, reduce preload. Anything that reduces preload, we do not give in right ventricular infarction. All right. However, we do give normal saline because increasing the volume, that means increasing the preload. We do give atropine. We give dobutamine, especially if shock is going to persist despite fluid, and then perform right-sided ECG. All right, V4R, where we see ST elevation more than 1 mm in V4R, which is going to confirm a right ventricular infarction. All right, and the references for it has been taken for lifeinthefastlane.com, because they have the best ECGs available that I could find. All right. Now, ECG changes in STEMI and unstable angina. All right now we are reading all about STEMIs. All right, so horizontal or down sloping ST depression, which is more than 0.5 mm. So now the thing is that in STEMIs there's going to be ST elevation. However, if it's acute or if the MI has been going on for a long time, and that is very common for people living on the countryside that do not have accessible healthcare, or people that are as we discussed, don't have pain as a symptom and they just keep on ignoring it, that STEMI can then convert into an STEMI as well, where we see, instead of elevation, we see a depression. All right, and thus the ST depression is going to be more than or equal to 0.5 mm in more than 2 contiguous leads. All right, so contiguous leads, as I said, either lateral ones, anterior ones, or the inferior ones. All right, all of them together. So for one group together, one after the other. So T-wave inversions, important point. T-wave inversion, it may be symmetrical and deep. It is a Wellen syndrome sign when it is seen in V2 and V3. So dynamic T-wave changes that resolve and reoccur with symptoms are particularly ominous. All right, wide ST depression and ST elevation in AVR. So AVR is supposed to be the opposite of whatever is the normal ECG. All right, so let's just consider this ECG. You see how our ECG is supposed to look like this, right? AVR, it's completely opposite. AVR, it's the other way around. All right, and if you see changes in ST depression, widespread ST depression and ST elevation in AVR, then that's a problem. All right, when ST elevation in AVR is more than 1 or equal to 1 mm with widespread ST depression in other leads, so AVR is supposed to be the opposite. So now it's the other way around, where there's ST elevation in AVR, whereas ST depression in other leads. Then this is going to suggest LMCA, left main coronary artery stenosis, which is a life-threatening emergency requiring immediate angiography. All right, because left main coronary artery is going to supply a lot of the vessels of the heart. However, let's just leave it for our next chapter. But you have to remember that if there's widespread depression and ST elevation in AVR, then emergency, we need to get an angio done. And normal ECG is going to occur in 30% of NSTEMI cases and even higher in unstable angina. Remember when we said the SNOOC classification? So just remember that as well. All right, so it should never be used to exclude ACS, and this is a point explicitly made by Murtagh, and it's a common AMC trap. All right, so patient with chest pain, normal ECG, negative first troponin. Remember this, first troponin, because there are questions they could ask you what's the next step. All right, then you need to do a troponin 3 hours later. So the correct answer is always to repeat the troponin in 3 hours. There we go. And do not discharge or do not reassure, and do not stress test immediately. All right, stress test is reserved for what? It is reserved for stable angina. All right, and serial troponins are mandatory. One negative troponin is never sufficient. All right, so ECG changes, evolution of a STEMI. All right, and because they could what they could do is give you an ECG and tell you that this patient had another ECG done in 30 minutes. What could be the changes seen? So 0 to 30 minutes, hyperacute T waves, tall T waves, broad spectral symmetrical peak T waves. This is the earliest change. All right, and this is in a STEMI, just remember that. And is often missed if seen with chest pain. Treat as STEMI. ST elevation will develop within 30 to 60 minutes. All right, now hour 30 to 4 hours. All right, 4 hours. So ST elevation develops often with loss of R wave amplitude in the affected territory. So R wave is going to disappear because ST is going to be elevated. All right, classic STEMI pattern. All right, and it indicates active transmural ischemia. Open the artery now. So angiography. All right, angiography or other pharmacological treatments, we'll come to it. There's an algorithm for it. All right, so hours today is 4 hours to 24 hours. So pathological Q waves begin to develop with whose width is more than 40 ms, more than one small square, and depth is more than 25% of R waves height. So R waves height, it's going to be 1/4, more than 1/4 of the R wave. All right, so Q wave is going to be more 1/4, and its depth is going to be more than 25% of R wave's height. All right, so Q wave, if you see this, it means there has been irreversible necrosis and they do not develop NSTEMI. Now in days, so there's going to be T wave inversion in the infarct territory, ST elevation is going to begin to resolve. As I said that, they could develop with, they could not have pain and they never come to the hospital, and then ST elevation is going to be resolved after they come after a few days. So resolution of ST elevation without Q waves may indicate successful reperfusion. All right. Now, after a few weeks, ST segment returns to baseline. T may normalize or remain inverted, and Q waves persist permanently. All right. All right. So persistent. Wait, say hi. This is my cat. All right, so persistent Q waves is going to be the marker of old MI and useful for identifying previous infarctions. So months down the line, we're going to see persistent ST elevation that do not resolve. All right, and if ST elevation persists for more than 4 to 6 weeks, then left ventricular aneurysm is a complication of this ST elevation. All right, now the investigations that we need to do is always 12 lead EKG. They're coming with chest pain. It could be pulmonary edema. It could be just pulmonary effusion. It could be a PE as well. Do a 12 lead EKG. Then high sensitivity troponin, CK and CKMB, chest X-ray. CKY, CK, CKMB important because it is less specific than troponin but is used for reinfarction detection. So FBUEC, creatinine, LFT, and BSL, though these come later down in the line, but they are performed on admission as well. So 12 lead EKG, it should be performed within 10 minutes of presentation and done before the blood test. Remember this, it has to be done before the blood test. They will ask that this patient comes and which is the first investigation you do. So we do a 12 lead EKG, all right, because it's the fastest one. You don't have to wait for results. You don't have to wait for the patient to be stable. That we have to do for while we're doing x-rays or while we're doing other investigation. 12 lead EKG always, all right, perform immediately. All right, then high sensitivity troponin. Again, first we have to perform when they come, then at 3 hours, or when they come at 1 hour, and with high sensitivity assay. So if you perform it after just 1 hour, then you have to use the high sensitivity assay. All right, it is not exclusively for ACS, and other causes such as PE, myocarditis, heart failure, or other types of pathologies can cause this troponin to be elevated as well. All right, so but it's a good test for searching for cardiac injury. All right, now coming to CK and CKMB, so troponin is going to stay elevated for 7 to 10 days and it cannot reliably detect a second MI, but CKMB falls faster and can re-rise. So if there is a new infarction, we can detect this using CK and CKMB. All right, chest X-ray, you can see a boot-shaped heart, so widened mediastinum, aortic dissection, do not give thrombolytics. Pulmonary edema, which means left ventricular failure, then normal chest X-ray does not exclude MI. FB, UEC, creatinine, LFT, most important, hypokalemia. All right, hypokalemia worsens arrhythmia risk in acute myocardial infarction, and they could give you a blood test showing hypomagnesemia. Hypomagnesemia also worsens arrhythmia, and then hypokalemia. So the worst one is hypokalemia. We need to correct that. All right, then TTE. Again, it's not first line, but it should be done if it's available on the bedside, especially if there's a doctor that can do it in the emergency department, and it's an amazing skill that you can also develop and you can add to the CV as well, and that could make you stand out from other candidates because it's an important skill to have. All right, so in acute phase, it is not the first line. However, while the patient is stable and you need to check the ejection fraction or the ejection rate, or for hypertension, or for if there's a ventricular septal defect, then TT is the go-to for it. Then coronary angiography, most important because you will get questions about this. All right, STEMI. So this is 90-minute balloon to door to balloon time. All right, and in STEMI risk is 2 to 24 hours. So STEMI, so there is something called door to balloon time, and which is 90 minutes for STEMI, whereas for NSTEMI it could be between from 2 to 24 hours, and it's the gold standard for diagnosis and treatment. All right, so we'll use coronary angiography for both diagnosis and for treatment as well. All right, now moving on to the exercise stress test. It's done for stable or low risk chest pain after acute phase has been excluded. All right, so if the patient has unstable angina, we never do this. But if the patient has stable angina and we need to reproduce those symptoms and get a reading on the ECG to check if there's an SVT or an let's say an artifact that came onto the ECG, then we use exercise stress test. All right, so the key test for defining chest pain as cardiac in origin, for its exercise stress test. All right, so troponin in detail. So give this a thorough read before before you go and sit for the exam, because it's very important, because the timelines are very, very important for troponin rise. Now, troponin could also peak 12 to 24 hours after onset of ischemia, and it is going to be elevated for 7 to 10 days or 5 to 7 days for troponin I. This window is used clinically. If a patient presents 5 days after an event, an elevated troponin still indicates an infarction. All right, now moving on to the AMC trap. So S1Q3T3, remember this, S1Q3T3 is always going to be pulmonary embolism, not ACS. The symptoms may be similar. There could be chest pain, dyspnea, and mildly elevated troponin. But if there's S1Q3T3, then we always think pulmonary embolism, not ACS. And we don't go off just troponin, because troponin can be high in both STEMI and in pulmonary embolism. All right, so context matters. Now, management for ACS. How do we immediately manage ACS? So remember, ACS, but not right ventricular infarction. All right, ACS has this mnemonic called MONA, like Mona Lisa. So we start off with morphine, which is for pain relief, and emerging evidence that morphine can delay and reduces absorption of P2Y12 inhibitors, and reduces antiplatelet efficacy in STEMI, and use when pain is not controlled by nitrates. Then we have oxygen, and it corrects hypoxemia only, and do not give hypoxygen routinely. All right, so because it can cause hyperoxia, which is going to lead to vasoconstriction, and especially if the patient history is that the patient was a smoker, has COPD, we don't give them high concentration SpO2, and we'll go over the reason why in the pulmonary section, because the COPD patients are not dependent on the same way that we both are dependent on high oxygen concentration. Their body is more used to the lower oxygen concentration for them to be able to have proper perfusion of their blood and oxygen change. Anyways, we're going off topic. So nitrates, GTN, pain relief, and vasodilation. Remember, it's an absolute contraindication if the SBP is less than 90 mmHg, or if there is right ventricular infarction, or if PDE5 inhibitors have been used within 48 hours. So sildenafil, vardenafil, or in the last 5 days, such as tadalafil. Okay, avoid nitrates if sildenafil or vardenafil used in the previous 24 hours, because they too can cause vasodilation. All right, and aspirin give first. So 300 mg chewed, not swallowed, because chewing is going to provide faster buccal absorption. If there is true allergy instead of aspirin, we give them clopidogrel. All right, however, if there is an active GI bleed, we have to now start weighing the risk to the benefit carefully. All right, good. So now you can go through this table after this watching this video, and you can find this PDF in the WhatsApp group. All right, again, the group link for the WhatsApp group is in the description below. So P2Y12 inhibitors. Now these are the other drugs that we can give to the patient, and some of them are given in the clinic, while some of them are given as outpatient for after the treatments or after the infarction has been managed. So P2Y12 inhibitors. So ticagrelor, stat, always give it first, or prasugrel, depends what's available. Then all ACS added to aspirin as dual DAPT or dual antiplatelet therapy. All right, prasugrel is contraindicated if the person has had TIA or a stroke, or is more than 75, or their weight is less than 60 kgs. And the common side effect is dyspnea. It is not dangerous, but it can occur in patients. And in this, we just reassure the patient. Clopidogrel is acceptable when ticagrelor and prasugrel are unavailable or contraindicated. All right, and we can see the contraindications for that. Then anticoagulations, unfractioned heparin, 60 U per kg IV bolus. Max is 4,000 units. All right, then infusion or enoxaparin 1 mg per kg. Then fondaparinux is, we'll go over this important caveats for it. So fondaparinux is preferred in NSTEMI, because there's less bleeding than low molecular weight heparin, and there's equivalent efficacy. And STEMI going to PSCI, add UFH or unfractionated heparin, bolus at cath lab if patient receive fondaparinux, adjust all anticoagulation for renal impairments. All right. Now beta blockers, metoprolol, if the patient is hemodynamically stable, and rate control reduces O2 demand, reduces VF risks. All right. Contraindications, you can read them: high intensity statins, atorvastatin or rosuvastatin, and ACE inhibitors. All right, ramipril, prendopril, and these should be started within 24 hours. All right, and the main reason why we give ACE inhibitors is because they're going to reduce left ventricular remodeling and mortality. However, they are contraindicated in patients who have had a history of asthma. All right, so STEMI reperfusion strategy, primary PCI versus thrombolysis. Now, the main reason I've added this is that there have been question about this: if the center is capable or access is available within the first 120 minutes or first 120 minutes or first medical contact. And again, door to balloon time is less than 90 minutes, and the agents and details is coronary angiography plus balloon inflation plus stent deployment, and most stents are DES or drug eluting stents, and the patient is going to require dual therapy, and it is superior to thrombolysis. All right, now coming to thrombolysis or fibrinolysis, this is only done if PCI is not achievable within 120 minutes. All right, for example, if they give you a scenario that you're in a GP clinic, or working in a rural clinic, or you're running camps for checking up on people. All right, now door to needle target is less than 30 minutes, so in this the time period is lesser than PCI. All right, and these are the drugs which are preferred or not. Contraindications: ATSI, you can read that later on. Then we have rescue PCI. We do rescue PCI if there's a failed thrombolysis. All right, and we do not wait for further medical therapy and transfer immediately for angiography and PCI. All right, and this is also done if there's persistent hemodynamic instability in the patient. Then invasive strategy: if there's successful thrombolysis in setting where PCI was not immediately available, then we plan routine angiography. All right, 3 to 24 hours after successful lysis, then thrombolyze first to open the artery, then transfer to PCI center for angiography. All right. All right, so contraindications to thrombolytic therapy, and this is one of the most important tables, because they could give you the contraindications and tell you that what treatment do you go by. Do you go by thrombolysis? Do you go for PCI, or do you just wait? All right, so absolute contraindication: do not give thrombolytics. So you can go through the table, but it's usually if there's suspected aortic dissection, which is the most important one; active internal bleeding, if the patient has had any past hemorrhages or strokes in the last 3 months. So hemorrhages in the past at any time in the patient's life, or strokes in the last 3 months. And relative contraindications: so relative means you have to weigh out the risk and benefits. All right, so if there's uncontrolled severe hypertension, prior ischemia, strokes, dementia, traumatic or prolonged CPR, or major surgery in the last 2 to 4 weeks, pregnancy or within 1 week of delivery, or they had active peptic ulcer disease, or they are already on a current anticoagulant therapy. All right, so important point, you can go over this as well while you're reading this table, but it is: when do you give it, when do you not give it. All right. Now coming to NSTEMI, the NSTEMI management, or NSTEMI and unstable anginas management. So one thing is that there is something called the GRACE score. Now, GRACE score is not something that you should worry about, because there's an online calculator available. It calculates based on weight, age, and gender, and the other risk factors the patient is on. And the same for CLIP class. So CLIP class, you don't need to calculate it. There's an online calculator available for it. All right, so alright guys, sorry, I had to get my charger. So risk stratification, which is the GRACE score, as I was telling you about the CLIP classification. You don't have to know how to calculate it, but there are online calculations available for it, and there is just CLIP classification 1, 2, 3, and 4. So based on that, if you can find the GRACE risk category to be low, which means it's less than 109, that means the in-hospital mortality is going to be less than 1%. All right, intermediate is between 109 to 140. Its in-hospital mortality is 1 to 3%, and angiography within 24 to 72 hours of presentation should be done. Then if the GRACE risk category is high, that means that in-hospital mortality is going to be more than 3%, then angiography within 2 to 24 hours should be done, or immediately should be done within 2 hours if any of the following are present. and this includes refractory ischemia, even though we have given all of the maximal medical therapy, hemodynamic instability or cardiogenic shock, life-threatening ventricular arrhythmias, acute heart failure or mechanical complications. And then we come on to the medical management for NSTEMI or unstable angina. All right. We start off with aspirin and ticagrelol, that means DAPT as above. All right, and then anticoagulation, and beta blockers. And remember, all of this is going to be given while we are waiting for the patient to get an angio done. So high intensity statins, GTN for symptom relief, ACE inhibitors, and especially no thrombolytics. Absolute contraindication in NSTEMI and UA. Thrombolytics increase bleeding time without benefit in partial occlusion scenarios. All right, remember, NSTEMI, unstable angina are not transmural. They are just partial occlusions. Now after MI, post MI complications, this is very important. As I said, that they could give you different time periods, and they could ask you that what is the complication that the patient is having right now. So first one, within 24 to 48 hours we are going to get ventricular fibrillation because of reperfusion. Then cardiogenic shock could go from hours to days, and acute mitral regurgitation is 1 to 7 days and peaks at day 3 to 5. I've seen a lot of questions about acute mitral regurgitation due to papillary muscle rupture. Now you could also go over the clinical presentations, but for time's sake I'm keeping this video short, so I'm not going over it myself, but you can read this while going over this PDF. All right. Then VSD. Now VSD is going to occur after acute mitral regurgitation. All right, and it's going to be between 3 to 5, and there's going to be septal necrosis that's going to happen, and because of that we have 3 to 5 days. Then free wall rupture, again 3 to 5 days. And remember that all of these ruptures are going to occur between the 3 to 5 days period, because all of these ruptures take time to develop. Then early post MI pericarditis. So early, it's 1 to 3 days. Dressler syndrome is late autoimmune pericarditis. Remember earlier I said we need to differentiate between early pericarditis and then late autoimmune pericarditis. So both of them are pericarditis, but one of them is autoimmune mediated, which happens later on, because as you can guess that autoimmune functions are going to take longer to come into play, whereas early post-MI pericarditis is going to occur 1 to 3 days. All right, then left ventricular aneurysm is going to take weeks to months post-MI. Now, Dressler syndrome versus early pericarditis. So it's solely based on timing, if as long as we are concerned for the AMC questions. All right. So as I said, early is going to be 1 to 3 days. Dressler syndrome is going to be 2 to 6 weeks, usually around 6 weeks. All right. All right, good. So both conditions are going to share a saddle-shaped concave ST elevation across multiple leads, pericardial friction rub, pleuritic chest pain. So, patient bowing ahead so that they'll feel more relief from their pericarditis. That could be a symptom. So secondary prevention. How do you prevent, and besides just doing lifestyle changes? So the drug regimen that we use firstly is going to be antiplatelet and aspirin, lifelong. Antiplatelet, which is P2Y12 inhibitors, 12 months post ACS minimum. And after DES, which is drug eluting stent, it's 6 to 12 months. After BMS, the minimum is going to be 1 month. All right. And there are different trials that have been done. So you can see the Plateau trial, Cure trial. I've not seen any questions about this, but that could come that the patient is using antiplatelet with the Plateau trial or the Cure trial. So just have a look at it. Just to get the knowledge of it, but it's not very essential. So statin, high intensity statins, again lifelong. ACE inhibitors, ARBs, lifelong. Then beta blockers is going to be given for 3 years minimum, and if the left ventricular ejection fraction is less than 40%, then again lifelong. Aldosterone antagonist, lifelong if LVEF is less than 40%, and there's heart failure symptoms or diabetics post MI. All right. So again, nitrates is going to be PRN or as required. All right, so we use ABCDE for this. So secondary prevention is aspirin and ACE inhibitors, atorvastatin. B is beta blockers and blood pressure target is less than 130/80. Then C, clopidogrel, ticagrelol, which is DAPT for 12 months plus cholesterol. So LDL has to be less than 1.8. Diet, Mediterranean type, diabetes management and driving restrictions. So we'll come to the driving restrictions below, because those questions are getting more and more common, not just for MIs but for also diabetics, for epilepsy, for a lot of neurological disorders as well, so post-stroke as well. Then exercise more than 150 minutes per week, moderate intensity, education, eplerenone if ejection fraction is less than 40%, and there's heart failure or diabetes mellitus. So cardiac rehabilitation, smoke cessation, diet, physical activity, weight, target BMI is supposed to be 18.5 to 25. So they could give you the weight and the height and ask you to calculate the BMI. So you should remember that. Alcohol intake, so 2 standard drinks per day with 2 alcohol-free days per week. All right. Men with hypertension should be maximum 1 standard drink per day. Right. So coming to the driving restrictions, now this is something new that has recently been introduced, and they've been asking a lot of questions about driving restrictions. All right. So if the person has a private unrestricted driving license, then 2 weeks following uncomplicated MI. All right, no symptoms of unstable angina or heart failure, able to perform activities equivalent to driving without symptoms, and document advice in medical records. Patient must not drive until restriction period has passed. So 2 weeks following uncomplicated MI, that's the restriction period. Then commercial, it's minimum 4 weeks. And they must undergo exercise stress testing and meet performance criteria. Then documentation, formal specialist review document. All advised patient must not operate commercial vehicle until he has been cleared. Then aviation, private pilot certificate, indefinite pending specialist review. This aviation I've not seen yet. However, it could come in it should start coming in the future because it is there in the guidelines now. All right. It requires formal cardiology assessment, CASA or CASA, Civil Aviation Safety Authority application, and they require 6 to 12 months before returning to flight. All right. And it is the examination is going to be done by designated aviation medical examiners. We can't do that for them. The AMC test driving restriction, know that the 2 week restriction for private license and 4 week minimum for commercial license. All right. Now these are a few of the questions pertaining to each and every single topic that we covered today. So one question for each topic. Now there's the question. If you want, you can pause and select an answer right now, and I'll go on to the answers, and scroll down. But each topic is going to have a question with the answer and the explanation as well. All right. I think there are 5 or 6 questions over here. So 5, yeah. So 5 questions. And now we come towards the end of the video. This is the mnemonics reference table, all of the mnemonics we did today. The 3 no 4 yes rule for RV infarction: no diuretics, no nitrates, no morphine, IV normal saline, nitropine. This is important, right ventricular infarction, because this is something that could be a trap set by the AMC, and it's better that you know this right now so you don't fall into this trap and lose a mark. All right. Now complication timeline, important as well: 1 to 3 weeks, 3 to 5, 2 to 6, and then weeks to months. And these are all of the references this is the reference table for all of the values and the time periods, and this is all of the references that I've used to form this one guidebook chapter. All right, now before we finish, I would like to go over the ECGs again, because of a few ECGs I would like to go over for this topic. So right now we have anterior septal STEMI. And remember, for anterior, where do we look at? Anterior is going to be V1, 2, 3, 4. All right, coming back to this. So V1, 2, 3, 4. We look at that, we see an ST elevation. So there is hyperacute T waves in V2 to V4. Then there's ST elevation in 1 in AVL with reciprocal ST depression in lead 3. Then we have Q waves are present in the septal leads V1 and V2. Then we have this means that there's hyperacute anterior septal STEMI because of the presence of the Q waves. All right. Now moving on to the hyperacute anterior STEMI. Again, these they are hyperacute T waves in V2 to V6. You can see that the peaks over here, the second peaks over here are the T waves, and they are most marked on V2 to V3. All right, with loss of R wave height, normal sinus rhythm with first degree AV block. These are premature atrial complexes. All right. Now moving on to the same patient's ECG, but it was done 40 to 50 minutes later. That was done acutely. This was done later on. So there's progression of ST elevation. Now we can clearly see an ST elevation. All right, and Q wave formation in V2 to V5. All right. Now the ST elevation is now also present in lead 1 and AVL. All right. Now what was lead 1 and AVL? Lead 1, lead AVL were the lateral leads. So that means this is now you're facing with anterior lateral MI. All right. Moving on to the anterior lateral STEMI. Again, this is acute. We see V2 to V6, first lead and AVL. all right, and reciprocal ST depression in 3 and AVF. Now, what was 3 and AVF? 3 and AVF were the inferior leads. All right. Now, ST, so we have extensive anterior STEMI, which is again acute but not hyperacute. Then this is the tombstoning pattern. You should all remember this. And, these tombstones that you can see from V1, 2, 3, 4, 5, 6. I mean, it's not that prominent in V6 as compared to V4 and V5, and it's present throughout V1 to V6 and even in the higher lateral leads 1 in AVL, and it is seen in LAD occlusion and indicates a large territory of infarction because all of these leads are getting affected, and there's a very poor left ventricular ejection fraction and high likelihood of cardiogenic shock and death. So this is an emergency at that point. So we have anterior inferior STEMI. So you can see that ST elevation is present throughout the precordial and inferior leads. So inferior leads were 2, 3, and AVF. Now there are hyperacute T waves, most prominent in V1, 2, and 3. You can see those as well. Q waves are forming in V1 and V1 to V3, as well as lead 3 and AVF. Alright, so anterior inferior STEMI, all of these are overlapping. So we go back to this table. So both of these sites are overlapping, and that's where we will be ending our topic today. So this was just the first chapter, and we have a lot more coming later on, and I hope that this have been of benefit to you. If you are new at your journey, hopefully this gave you some structure to it. If you're on the same path as me, hopefully this was a good revision. And if you have already passed your AMC, or you're seeing this just to review, if you could let me know if I made any mistakes. Let me know in the comment section down below. If you like any additional material, if you have any questions regarding the exam, the registration process, or the topics and whatnot, just leave a comment below. I read all of them and I reply to all of them as well. So hope you like the video, and see you in the next one.